curvature. It hits the posterior pharynx and it just slides down. Then meanwhile, it's not a bad idea to ask the patient to drink some water using a straw. Now, I'm sure you all putting Ryle's tube day in and day out, but it's not a bad idea to think about it once again. If you know it, it's good to reinforce, and if you do not, it's never too late to know. Now, important thing is Ryle's tube is a very critical, very important tube which we all have to manage in the post-operative period, and invariably there is a patient in the ward rounds with a Ryle's tube in situ or a stoma, where the questions pertaining to Ryle's tube are definitely asked. Now, Ryle's tube, besides being of relevance in the therapy, is diagnostic, in the sense that what you aspirate shows you about what is the level of obstruction. If it's feculent, you know it's obviously obstruction. Slightly lower down, color of the bile shows you whether the bile is coming mixed from the succus entericus. So various, whether it's hemorrhagic or it's got some associated other color, then you can think in terms of feculent could be also happening with gastrojejuno-colic fistula, many things. So it is a very important tube which we must learn to manage. At the same time, regular aspirations as were practiced in the past, 6 hourly, etc., they are no longer practiced. We leave the Ryle's tube there, it aspirates, it works entirely on its own. Now, moving on to the question that I was initially mentioning, what if there is more than 3 liters of fluid coming out in 24 hours drainage from a nasogastric tube? Now, think that it could be in the duodenum. Think duodenum, that's what the dictum is. It could be well in the duodenum and you must take, not in the stomach, take an x-ray. When should you remove it? When abdomen is soft, patient has pars flatus, or the bowel sounds are nice and good, you got no business to have a Ryle's tube. Doesn't matter the amount that is coming out, because it itself could be the cause of that drainage. It can precipitate ileus by itself. So it's important to know when to critically get it out. The good thing about Ryle's tube is you can always put it back. So it is not really a blunder if you got it out. It's not like a chest tube that you have to bother about, in the sense that if you removed it, taking into account the patient's general condition, abdomen, if it is a soft abdomen, patient general condition is good, he's hungry, he's pars flatus, then you haven't done anything wrong by getting it out. Instead, if you leave it behind, it's a problem. It's a good practice to remove tubes in the morning rather than in the night, because in the morning you have the whole day to watch this patient. In the night you may leave the patient to a care of maybe a couple of residents who are managing the whole ward. So it's much better to remove a tube. It can wait that long and you can do that in the morning. Now, coming to just a word about knots. Now, this was supposed to be included in the day's discussion. It so happened that it is coming at the fag end, so I'll quickly run through them. How do you actually define a knot? It's often interchangeably used with throw, which is not correct. The terms are totally different. Two throws, at least 2 throws make one knot, and a throw is when you take one thread to the other side. And when you cross 180 degrees, it's a square throw. And 2 square throws make one square knot, which is the mandatory basic knot that each surgeon has to learn to put. Now, if you take the same throw, we'll probably have we have it included in the DVDs, or otherwise at some other point of time it can be actually demonstrated also. That if you take 2 throws through the same loop, it ends up being the first surgeon's throw, and then you can wrap it up by putting a third one. Lots of surgeons were in the practice of putting a single and then a single again, that is simply 2 throws, making it one knot, and the third one was not required. But in that scenario, you have to leave the ends very, very long so that the throws don't slip. And to avoid that problem, leaving the thread inside is a problem. So you put a third throw. So classically, 2 throws make one knot, and you put third one for the road to ensure that it doesn't slip. But when I'm talking about 3 throws, it's essentially about threads like silk or catgut. There are more throws required for monofilament sutures, which are synthetic, and they have a memory. The memory of a suture is its tendency to go back to its original form or position. They tend to have a slipping of the knot, and it is not a very good practice to hold a knot with an artery forceps, because each time that a thread crosses, for the benefit of all of you, we lose the tensile strength by about 15 to 20%, and the thread is weakest where the knot is. For all those people who have flown kites, you would know the kite gives way at the knot. So if you're holding at the knot, you're probably holding at the weakest point, and you're only as strong as your weakest point, isn't it? Now, in that scenario, it's important, if you want to hold the knot with an artery forceps, it should be what we call as rubber shot, or an artery forceps with guarded latex on it, or otherwise it is best avoided. And therefore, the term, so that therefore the use of surgeon's knot came into practice. Surgeon's knot do not require, repeat, do not require holding with the artery forceps because they do not slip. And surgeon's knot classically is 2 throws followed by 1. And if you follow that, those 2 throws with 2 more, it becomes Mayo's knot. So surgeon's knot is what we classically normally put. Now a word about the instrument tie, and I'll wrap it up by mentioning the granny's knot. Now instrument tie is what we learn the first. Most of us are taught instrument tie first. And you keep hearing about the clockwise and the anti-clockwise business. It doesn't work that way. Actually, it's exactly the same way that you put the hand knots. You must cross the threads each time that you put the throw. If you haven't crossed the threads, you put a granny. And if you put a granny, it's a slip knot. So slip knots are not supposed to be put. Slip knots or granny knots are used by our grannies while knitting. They can slide them down. That's why they're called slip knots or granny knots. They have no place in surgery except when you want deliberately, say in laparoscopic appendicectomy, where they prepare a slip knot which can go down the appendix and you can slide it in with a push knot pusher. Now slip knots are not used, so I am emphasizing that point. So if at all you have to put a knot in the ward, you have to learn to put a proper surgeon's knot or at least a reef knot, which can be put with the hand or with the instrument. Now when you take a bite, of course it needs visualization, and you would best learn by looking at it. We try to stay within the V of the 2 threads, and clockwise and anti-clockwise is not really important. Crossing the threads is important. Now a word about chest tube insertion. Now this is often done as an emergency procedure in pneumothorax, hemothorax, chest injuries, where the chest tube can end up being diagnostic as well as therapeutic. Diagnostic in the sense it will show you what is coming out, which will indirectly show you what is injured. Now actually diagnostic function of chest tube is along with its therapeutic function, that is, it ensures that both the visceral and the parietal pleura can get together and that dead space is obliterated. It works well in most situations, and we know that it saves lives. Now we generally do it in the triangle of safety. And what are the boundaries of triangle of safety? We all read during a study during our MBBS days. This is bounded by anterior axillary fold anteriorly, posterior axillary fold posteriorly, and the bottom is by the 5th rib. This triangle is the safest place to put in the chest tube. Lower than this could be dicey on right side, and you can get into liver. On the left side you can sometimes get into spleen. Sometimes the diaphragm is pushed up in a associated pneumoperitoneum, and you can get into the liver. It does happen. We have all seen it happening in the wards. So one has to be extremely careful about putting it in the triangle of safety. Now how do you actually do it? We do it by administering local anesthetic at the proposed site. We incise the skin in usually the 4th or 5th intercostal space, as I mentioned. We usually perform a blunt Kelly clamp dissection. Kelly clamp, or you can use a Kelly or an artery forceps. It's a type of artery forceps only. You perform it over the rib, so you get into the pleural space, and then you put your finger inside rather than a trocar, which was a practice in the past. You create with the finger, you make sure that the lung is away, and then you try and place the tube posteriorly and superiorly, although a lot of people argue that this doesn't matter because the drainage is by capillary action rather than anything else. Now these are some of the questions relating to chest tube in the ward rounds. Is the chest tube placed under or over the rib? It's always over the rib. We remember that formula of VAN, vein, artery, nerve. VAN, we are likely to injure if we go under. We are likely to injure the vessel. The commonest cause of hemothorax, which is iatrogenic, is injury to the intercostal vessels. Incidentally, for your benefit, that's almost a quiz question. Now, what are the goals of chest tube insertion? I've already mentioned. You drain the pleural space, you oppose the parietal and visceral pleura, and you would make sure that the last hole, which is usually seen as a break in the radiopaque line. It's actually a radiopaque line which goes right across with the tube. So where the break is, the hole is. You must ensure this break is actually inside the pleural space. Otherwise, you're likely to have the air leak within the subcutaneous area. Now, this is how you actually find out. Now, what are the indications of thoracotomy in a ward, or as it is called ERT, emergency room thoracotomy? You put in a chest tube and suddenly patient throws about 2.5 to 2 liters of blood. But the point is sometimes it stops immediately after that, and the patient's vitals are maintained. He is hemodynamically stable because you're not managing just the chest tube, you're managing the patient. If he's hemodynamically good, sometimes you can observe, but by and large, with so much of blood loss, it is unlikely that he's got something mild. Number 2, If he's draining bile, that is, he's got injury, or he's draining esophageal contents, it's an injury to the esophagus which is not managed conservatively, as we all know. It should be managed surgically. Or if the patient continues to throw blood more than 300 ml per hour, these are the copybook indications for thoracotomy. Emergency room thoracotomy is also done in situations where there is a cardiac tamponade. How do you identify there's a cardiac tamponade? It's a silent heart with congested neck veins. There's no other shock where neck veins are congested. All shocks are associated with collapsed neck veins. The only shock where the JVP is raised and the neck veins are congested is cardiogenic shock. So one must be cautious about it. And then we go for that Beck's triad, where you find a silent heart, pulsus paradoxus, congested neck veins. Now these are the indications for emergency room thoracotomy, and very often you would need the help of a senior surgeon to come and help you. The important thing at this point of time is, suppose you're left alone and you're the one who's managing or manning the ward, you should be in a position to aspirate out this blood, which is usually done by putting a needle up from the costoxiphoid angle up towards the midclavicular line while pointing towards the midclavicular line. The needle keeps going up, and there is initially resistance, and after that the blood starts coming out on its own. But the important thing is the stethoscope is on the heart. As the blood comes out, the heart sounds start appearing, which is indicative of the fact that you are in the right place. And number two, this blood does not clot, unlike blood which will come from elsewhere. Now, when do you remove a chest tube? That's a very important question which is often asked. Excuse me. The chest tube is removed when it has stopped functioning. Now, what do you mean by that? The chest tube is usually connected to an underwater seal for reasons we all know. We don't want to suck back air into the pleural space. With all the good work that you have done, it will be lost in that minute. Now, what you do is you wait for the column to stop moving, and you also ensure that chest is expanded. Simply stoppage of movement of the column is not exactly the reason to think about it, because the chest tube could be blocked, and that is when you do the run over of the system. I'll go through that in the next slide. But actually we stick to the chest tube as long as it is draining, and if it is draining something which is in the form of blood or blood mixed fluid, it's good to keep it there. It's not a bad idea to auscultate the chest every day, twice, to make sure that the lung is expanding, the air the airflow is all right on both sides, and then to get a chest X-ray to make sure that the lung is expanded, because it is often that when the lung is expanded, the chest tube stops functioning because it doesn't have a function anymore. Otherwise, the chest tube can stay. There are occasions where the column may not move, but the patient, when coughs, there are bubbles in the water column, which would indicate a bronchopleural fistula. That would again mean that you have the chest tube in place before the patient goes in for bronchoscopic sealing or for thoracotomy or for subsequent management of bronchopleural fistula. Now, we have therefore understood that you must put the chest tube in the triangle of safety in the manner that was just described. We try to go over rather than under the rib, that we decided to, the space that we have decided to get into. We connect it to the underwater seal, and we never ever clamp the chest tube. That's the next question. Should a chest tube ever be clamped off? The answer is a big no. Never, 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 except to run the system momentarily, which is given at the bottom of the slide. Momentarily occlude the tube, and if the air leak is still present, it is from the tubing or tubing connection, not from the chest. This is something which falls in the purview of a resident to ensure that the chest tube is functioning, it is not leaking, and that the air leak is not from the chest cavity but from the chest tube. It's important, very, very important, to ensure that chest tube is not pulled out, and it's important to observe that there is no surgical emphysema, which is called surgical because of the fact that it happens in surgical wards. Otherwise, it's like any other subcutaneous emphysema where air is leaked into the subcutaneous tissue. It doesn't need any extra management unless it is compressing on trachea, where we can release it in the neck. Otherwise, more or less, it's almost a sure shot indicator that probably one of the holes of the chest tube is actually outside. Now, it's important therefore to manage this tube carefully. Now, a word about central lines. Now, often we have a situation where residents in ICU care or those in the care of surgical patients or surgical ICU have to put in these central lines. I'll not get into the details of how it is actually put, because all of us get to see them, get to put them also. They're usually put into major veins, that's why they are central. The good thing about them is they're very close to the heart, which again is which is a double-edged sword. Since you're very close to the heart, you're leaving the infection to go very quickly there. Now, often associated questions relating to the central lines are, two very important aspects. One is CIS, that is catheter-induced sepsis, and the other one is CRS, which is catheter-related sepsis. This is often asked from a resident. If a patient has got a central line in situ for about 3 weeks or 2 weeks or even a week, if he runs high-grade fever, this could be one of the sites. Now, how would you know it is catheter-induced or catheter-related? What is the difference between these two terms? These are ICU terms for the infection that is associated with central lines. Now, catheter-induced sepsis is whenever you remove the central line, the tip is cut and sent off for culture, which is a routine protocol in every center. Now, same time, if the blood culture is sent and if both culture the same organism, it is supposed to be CIS, which has got a bigger implication than CRS, where the two culture differently. That is, there is a catheter-related sepsis which will be confined to the area where the catheter is. It will not produce the kind of gram-negative septicemia which is associated with CIS. CIS is a major killer in most ICU settings of surgical patients. Now, it's important that you can use subclavian approach, internal jugular vein or femoral vein approaches. Cordis is a type, so you shouldn't be unfamiliar with these terms because very often you hear it. Cordis is a large central line catheter which is used for massive fluid resuscitation. Although it should be understood that we do not use central lines for massive fluid transfusions, they are associated with the risk of infection, as I just mentioned. Or we can use this essentially for the estimation of pulmonary artery wedge pressure, etc. Swan-Ganz catheter can be guided through this. Hickman or the Hickman type is the most commonly used catheter in most ICU settings. These again need a lot of care in the sense that their cuff gets blocked and you have to be very careful that they are pressed only when required. They are very commonly used for giving, they are ports for giving chemotherapy also. They are very vulnerable to infections, therefore one has to be careful about clearing them off once in a while and changing them frequently. It's not that you change them every day, but you don't keep them for 4 weeks. That is, you put in a central line and you've forgotten about it. Patient keeps on running high-grade fever, although in surgical scenario we all used to understand pus somewhere, pus nowhere, pus under the diaphragm, and that's the most common cause of fever. But there are many other very trivial, very minor issues which can actually cause fever, and it is now being observed that catheter line or the central line are the most important causes. Now, what are the major complications when we are placing them? I have already talked about the complications when they are in place. Now, the complications that can happen are related to techniques. They disappear with doing them more often, like any other surgical procedure or any other procedure in the ward. More you do, more you learn, more you learn, more you do, and at the end of the day you cause more harm if you have actually learned the right way. Aphorism of Morrison, which should be practiced and mastered by every resident, is above all, do no harm. If you cannot do anything, at least do not do any harm. Now, the major complications include bleeding, which would mean that you got into an artery instead of vein, or you punctured right across the vein. You can get into the pleural space, produce pneumothorax. You can get into the cardiac space, produce dysarrhythmias, etc. Now, finally, towards the fag end, I would like to have a word about tracheostomy. There is no reason why a general surgeon should call, a resident surgeon should call an ENT surgeon for a tracheostomy, because a surgeon who is managing much more difficult problems in the neck and also in the body and who's managing trauma cannot depend on an ENT surgeon for a tracheostomy. So all residents, it's our practice to train all of them into doing it. I'm going to share with you a clip which was done by a resident only, where tracheostomy was performed in a patient who needed it urgently, because these patients cannot wait. Tracheostomy saves lives. And it is actually, in the Western world, it's mandatory for a surgeon before he's finished his SHO trainee to know or to master tracheostomy. He has to demonstrate that he can actually do it. Now, it's essentially there taught on pigs, and later on they do it on humans, but here we get to see them so often that it can be done. The indications are airway blockade due to any cause, patient getting into respiratory distress when you want to reduce the physiological dead space, and a common scenario is a flail chest where you don't have enough ventilators in a third world scenario. You can't attach, the management of flail chest is IPPV, intermittent positive pressure ventilation. For that you need a ventilator, you need a tube in, and you need a patient on ventilator for some time. So it's important in these cases to reduce the physiological dead space, and we actually achieve a very fair outcome with tracheostomy. Percutaneous tracheostomy, where you just guide it through the cricothyroid space using a fine tube or whatever, and you guide it in. Classically, tracheostomy is done in the lower part of trachea for obvious reasons. In the upper part, there is larynx and also the thyroid isthmus, which should be avoided. It is safer to do. It is better to use a midline vertical incision. because you're not likely to enter areas that you don't want to enter. You have a better access right straight down to trachea, and like most other neck surgeries, it is done with head and up to reduce the venous congestion. But the problem of head and up in any neck surgery is that you create a negative pressure within the veins. Air embolism is an issue, so you should take care of veins as soon as they're punctured. They should be ligated. They shouldn't be allowed to be bleeding because they suck in air, and at the same time trachea is opened vertically, and then you can put in a tracheostomy tube. Now this is a clip. Hopefully if it works, then you'll be able to see that we select normally this position. The head end is extended, the neck is extended, and it is possible to go. I'll just show you the landmarks. This is where you palpate for the thyroid cartilage, look for the cricoid, and go 2 to 3 centimeters below this. In the midline, as you make an incision, it's pretty simple, straightforward job. You have the strap muscles coming your way. It is not a huge thyroid when you're doing tracheostomy. You can simply split them and you go straight on to the trachea, taking care of pretracheal fascia, and you can do that. Now this is to show that roughly you can measure it with your 2 fingers, and you can actually make a midline cut. I'll just run through this. We're running short of time. I'm sure you're familiar with tracheostomy, and if you're not, you must go and see it happening somewhere. It's mandatory to know tracheostomy. You got no business to be in the emergency ward if you cannot do tracheostomy yourself. It's mandatory, and it should be taught to each resident. These are 2 Dunhill retractors that you use for retracting the strap muscles. You keep going deeper, and ultimately you find trachea. And this is to share with you a clip of venesection if it comes through. Now venesection is usually done when you cannot get an access to the vein in a normal circumstances. It can happen in patients of burns. It can happen in inaccessible sites being all, accessible sites being all damaged, or edema being there, when you actually cannot find a vein in the situation that you want to see. To find a vein, but you cannot find it. It's mandatory to ensure a lifeline, and therefore it is required to be done. Now a few words about venesection. If we are familiar, it's a very tempting desire. Most people like to do it in the lower limb quickly because they find a great stiffness waiting to be opened, but it's better to do it in the upper limb, in the deltopectoral groove, which is considered the classical side of doing it. Deltopectoral groove is felt by abducting the arm and feeling for the pectoralis major as it goes down to the lateral lip, and lateral lip of the humerus, that is, and you find there's space there. Invariably you'll find a vein. It is closest to the heart, and you can push in a good cannula inside. And the other options